Good evening, everybody. Welcome to our meeting of the Health and Adult Social Care Overview and Scrutiny Committee. I'll start by reading the housekeeping notice. Please note that this meeting is being audio recorded by the Council for subsequent public broadcast. The meeting may also be audio recorded or filmed for live or subsequent broadcast by members of the public. Could I remind members and officers to use their microphones when speaking? There are no scheduled fire alarm tests. If the alarm goes off, please leave through the emergency exit at the back of the room and assemble at the front of the town hall. Finally, please could mobile phones be switched off or turned to the silent setting for the duration of the meeting. Yes. I'll start with item number 1, apologies. I've had an apology from Hazel Allen and Councillor Geary. And substitute members, Jane Kelly is substituting for Hazel Allen. Declarations of interest. Please could you have a look at the sheet on page 2 to give guidance regarding any declarations of interest you may have on the items included on this agenda. Anything else? Yes? Okay, thank you.
Just for clarity, my partner works for the council in this sector. I mean, he's in housing, but dealing with this topic.
Okay, thank you.
Declaration of interest, I also work for the NHS.
Thank you. Item number 4, the confirmation of the minutes of the previous meeting. Does everybody agree that they're an accurate representation of what happened at the meeting? Okay. I'll sign the previous minutes. Okay, now we'll move on to the action sheet. Welcome, Councillor. We only have a couple of items on the action sheet which are not completed, and I've agreed with the officers that we're going to be, from now on, removing any completed items after they've shown for one time completed. So the items that are still to be completed, the external scrutiny of the quality accounts, this work is currently underway. And our scrutiny plan for the scrutiny of the clinical services review, which we're going to be looking at when we look at our forward plan when we have our session in early June. Does anybody have any questions on the action plan? Item number 5, public issues. Oh, sorry. Sorry.
Sorry, thank you. This external scrutiny quality accounts, any idea when we're likely to get sort of sight of those?
And I think some of us have already had our details for our meetings. Item number 5, public issues. There are no public issues. So now we move on to item number 6, which is the big plan, commissioning strategy for adults with learning disabilities, progress report. And I'm going to hand over to Joe O'Connell and Mark Harris and the People First Forum, who are going to do a presentation. And then after the presentation, we're going to hear from the officers who have a report, and then we can ask questions. Over to you.
Good evening, everybody. My name's Joe O'Connell, and unfortunately Mark Harris from the Clinical Commissioning Group is unwell today, literally, so as last minute not been able to attend this evening. So when it comes to the questions time, Sally Sancroft from the Clinical Commissioning Group will come up and be available to offer from the Clinical Commissioning Group any health-related questions, perhaps. But before we do that, I'd like to introduce you to Shane and Amanda, who are here from People First Forum, which is a local self-advocacy organisation supporting people across BCP who have learning disabilities, and they're going to do a quick presentation. Okay. Are you guys happy? Do you want to stand or sit? What did you decide you'd like to do? Press it there and you're on.
People First. Can you hear it? People First Forum, giving a voice to people with the learning disabilities. Who we are. Emily and Smelling and Amanda Parsons over there. Share the jobs. Managers job share as managers. There's myself there, Amanda Frost, assistant manager, and Shane.
And Shane Singer, a trainer for People First Forum, but I don't just train trainers.
Not me, sorry.
We are People First Forum. We're a self-advocacy group for adults with learning disabilities. You may know Pool Forum and Bournemouth People First joined together in July 2018 before you, the councillors, did. We're now called People First Forum. Our vision is the world where people with learning disabilities are treated as equals, living safe and healthy lives. Our mission is to give people with learning disabilities the support and opportunity to live their lives they choose. Our membership, we have 820 members with learning disabilities from Bournemouth, Christchurch and Poole and other areas of Dorset. How we work together with the big plan. We're a part of the action groups that work towards the big plan and as a part of the Learning Disability Partnership Board. And I'm one that co-chairs, me and Sean Hayward do it with the gang. We talk to our members in different ways about all the area of the big plan. These are staying healthy, keeping safe, where I live, having a good life and right care and support. The bottom two are our task and finishers, and the others are the three action groups. Some of them used to be always all action groups and used to tire us all out, didn't it? Our services. Information, advice and advocacy. In 3 months, October 2019 to December 2019, we had 167 people call us for information, advice and advocacy. 113 was members, 21 were professionals, 26 were family members and 7 were other people. 12 people were signposted onto other services. 95 people were given advice or information. 22 people were given support. And were given 22 people again were given advocacy, 17 people were given other support. Our three main queries were about emotional well-being, speaking up, our groups and events. We also raised 12 welfare and safeguarding alerts in those months. Safe places. We have a safe place project, award-winning, went to London. We worked with chatterboxes on this to get 134 safe places in Bournemouth, Christchurch and Poole. A safe place is somewhere that you can go for help when you're out in the community. Our witness profiling service helps support victims and witnesses of crime who have a learning disability. This includes writing a report to help the court know how to support people attending the court with the person talking to different services. Easy read information, we call it see here, make it clear. And it's got a brass line on. We make easy read information for yourselves and other, and we've done it for council and health and other services. We've made reports and leaflets easy to understand.
Okay, so training. Can everybody hear? Oh, jolly good. Right, so training. We deliver learning disability awareness training to lots of different people, including Poole Hospital, East Borough Housing, BCP Council and the Bournemouth University. Quality checking. We offer quality checks to anyone that provides a service for people with a learning disability. These checks make sure that services are person-centred and meet the standards of the Bill of Rights Charter. Big night out with Suttles! Sorry, that was a bit loud. Sorry, got a bit excited there. So we have 2 club nights every year at Cameo Nightclub in Bournemouth. The Big Night Out with Suttles is for people over 18 with a learning disability. And it is a great atmosphere. And there are usually about, 600 people there. That's a lot, isn't it? And the Mix It Up Crew. The Mix It Up Crew are a group of learning disabled DJs. They perform at our club nights and have also performed at Camp Festival for the last 11 years. Is it me still?
Yeah,
Oh, it is me, right. Of course,
yeah,
yes, of course, sorry. I just didn't see my name on there, that was all. Sorry. Bill of Rights Charter. Members of People First Forum and People First Dorset wrote the Bill of Rights in 2004 and then updated them in 2011. These rights are the rights that most people take for granted. So the Charter is for organisations and services to sign up to say that they will support and work to these rights. The rights are to feel safe when going out, to feel safe in our own homes, to live where we want to live, to get support when and if I need it, to relationships and to say no, to confidentiality, to communicate, to independence, to adulthood, and to use public facilities, to transport, to good health care, to have our voice heard by the government, to freedom of speech, and one other thing, to have feelings. That was right, yeah, sorry. Our Bill of Rights is supported by 62 organisations across Dorset. We continue to support our charter. Is it part of your BCP Council plans? Is it part of the way you work? Do you check your services to make sure they are accessible and right for everyone who uses them? We hear stories in the news about how people's rights are not respected. the abuse of people with learning disabilities at Winterbourne View, Walton Hall at County Durham and locally at Purbeck Care. It is over 100 years since some women were given the right to vote, but people with a learning disability are still turned away from polling stations. Electoral Commission 2617. That's all right, thank you, Joe. That's all right. Half of people with a learning disability want to spend more time outside of their home, and just under half do not think they spend enough time with their friends. MenCat 2016. Just 6% of people with a learning disability have a paid job. Most of these people work less than 16 hours a week. MenCat. Among people with learning disabilities, men die on average 13 years earlier than in the general population, while women die in 20 years earlier. Equality and Human Rights Commission 2016. Our Charter is a way to make sure that rights are respected and that things are fair and equal for everyone. Any questions? Yeah.
So there we go. Shane, Amanda, that was absolutely sensational. I feel electrified from that presentation. It's absolutely brilliant. So thank you ever so much.
Anytime.
One of the things I was really interested to see your point about raising awareness amongst people, and I think that's really, really important. So one thing I'd like to ask you: do you think it would be really good if the councillors had an awareness session?
Not half.
Yeah. So
Yeah.
I tell you what. So that's something we could certainly take forward as something that we can do, because if you're present, do you do the presentations when you do the training? Do you actually come out and talk to?
Yeah,
Well,
we
Uni.
I'll tell you what, I'll book a
Uni
ticket
twice a
now
year.
because it was sensational. But thank you. That's something that we can certainly take back from this committee, because I think the more can raise awareness of everything, it empowers people. It gives it people understand. So I think it's really important. But thank you ever so much for that. It's been brilliant. Thank you.
Thank you. Is that it?
I
thought there was more. Oh, would you like more? Okay. Thank you.
Right. Thank you both for that really good presentation. I'm really impressed that you've now got 820 members. That's incredible. And is that number growing? And what are you doing to increase the numbers of members? One. Thank you. One of the recommendations for this committee is to recommend to Council that your Bill of Rights is adopted by the whole of BCP Council, and I'm sure there's nobody here that would not agree that that's a good thing. Just interested in how that's going to be done and how you would like it to be done, because I remember when it was the preceding council, when it's Pool Council, I think you came to a council meeting and you did a presentation, and then every councillor supported you. And is that something that you'd like to happen with the new, bigger council?
Thank you, and thank you for that brilliant presentation. I'm a bit bothered about this people being turned away from polling stations. Has that happened here?
That's why they brought out that nationally this easy read voting thing, because it will that's because is made, it would be, I think it would be before that, it like had nobody come up a previous other general election, and it realised like it was low ones, and so they made this easy read nationally, easy read thing to say, no, you should be voting and all that. And then we've been to like them where you meet the at Austin's, and
But then sometimes they do ask you who you voting for. Sometimes they touch. That's a silly question to ask. Because if we tell you, you're going to go, why only one? You know, you don't want that. That's naughty. No disrespect, mind. You know, love to tell you, but no. But it hasn't happened since. But I did vote last time, so that was very helpful.
Thank you.
Is there any more questions? I'll just ask a question. One of the points made was about do we inspect our own services to see if they're suitable? It sounds like you might already know the answer to that. Do you know? Or probably what I want to know is, do you think they're suitable? Do you find problems?
I suppose independently. I mean, that's like in Elf and others. They have like care and that does the nurse. That's why we have to fight to have when we work with brown language or anyone to do the quality checks, isn't it? Because they've had care and thingy coming in commission. You have to like fight for going in independently.
So probably helpful. So as well as so as well as the obviously we have our own contract monitoring arrangements, service improvement teams, and obviously the work that the clinical commissioning group doing, going in and checking the services that we commission. But what we have often worked with People First Forum and their preceding organisations before was around then doing quality checks, focusing on some of our independent day opportunities providers, because they're not regulated under the Care Quality Commission services, and sometimes people buy those services with direct payments, so we don't necessarily have a direct contract with our providers. So it's been really good that People First Forum have gone into those services and done quality checks around and then publish those, the results of those quality checks on services. And we're just agreeing now to do some checks in our residential care settings and some of our new care and support providers on the care and support framework. So we're just setting up those quality checks in those areas as well.
We did them right at the beginning when there was a moving on hospital living. Then we did what Joe was on about for Brian Language and Elf Watch thing, because they were twice funded. Then we've been to, I think Pool Forum went to Pool Museum, but then as we come People First Forum, we went to the retreat was the last check. We're waiting for Mark.
Yes, so for those who don't know, the retreat's the new sort of community sort of mental health service, which should be accessible as a universal mental health service for people with learning disability. So they went and did a quality check there to check how accessible it was for people with learning disability, recognising there's a higher prevalence of people with mental health needs compared to the general population within the learning disability population. So it's important that those services are accessible.
That's all the questions.
Okay, I think the next presentation's for me, isn't it? Thank you. I don't know whether you want to stay for my bit or whether you're quite happy to chill back on the seats there. I'm entirely up to you guys. Yeah, do you want to, and then just in case Jenny needs to come up and stuff.
We can listen over there.
Perfect, you can relax. Thank you very much. Okay, so as I said, Mark Harris is unfortunately not with us today, so I'll run through the presentation, but this is Sally Sancraft from NHS Dorset Clinical Commissioning Group, and Jenny Collis-Heavens, who's the service manager with oversight for learning disability mental health services, also here and will be joining for questions afterwards. So just to sort of give you a bit of a context, it's just some information that's in the report. is that although we've got an estimated local population of people with learning disability across BCP of around just shy of 8,000 people, most of those people live very independent lives, have what we might call a very mild learning disability, and don't come into contact with services altogether. So then what you get then is a smaller group of people there of around 2,500 that will be identified as having a learning disability and will be registered with their general practitioner, their GP practice, as having a learning disability. And then again, of that, we have a smaller group of people within that group itself that will be eligible for what we would call commissioned care services and receiving a service. But there's somewhere between the 820 and 2.5 are people that will be known to our community learning disability services, receiving professional support from either the health staff that are based within there or our social care staff. But that just gives you a sense of the population that we're dealing with, but then actually what group of those actually require a commissioned service under the Care Act. I'm pressing my key button there, thinking it's the presentation on my key. So, as touched on by Amanda and Shane's presentation, they talked about the scandal at Winterbourne View, and that led to a huge programme of change across the NHS and social care around transforming care. That came to an end almost 12 months ago, but is really continuing much of the work under what is a new NHS Learning Disability and Autism programme. I think what we've got here is a sort of continued priority of work streams. A lot of that about trying to reduce the number of people that are in what we call specialist hospital accommodation, and actually keep that and targets to reduce the number within that, and also improve the quality of care for those people that do still require hospital treatment and about making sure that we're not people that are in hospital settings or in the community settings aren't over medicated. So it's a sort of thing to try and reduce that, to make sure that we're not over medicating people, perhaps who have behaviours that challenge services in particular. So just to sort of get you in terms of where we are in terms of our inpatient numbers, and this is as of 13th of February. We have sort of people that are commissioned by the clinical commissioning group, and they are typically what we would call non-secure hospital settings. So there were 14 people as of February in those hospital settings, 7 of which are from the BCP area. The target for the end of this year is to get that down to 11, and actually we think we're more or less on target with that, with people identified with accommodation and support plans in place, so that they are discharging either not by the end of March, by very quickly into April, is my latest understanding of where that's at. So I think we're pretty much on target there. This is where the NHS England themselves, and these are what we would call our secure settings. The target for that is 11, but we've only got 10 people across Dorset currently in it, so we've met the target there. And then for children and young people under the age of 18, we've got 4 people currently in a hospital setting, and target to get that to 2 by 2021. And the projected where we think we're going to be by the end of this financial year is that's gone down from 4 down to 3. So that's one of our BCP clients moving out of hospital. On the annual health checks area of performance, at the quarter 3 position, 34% of target, but it's a kind of target that builds on, and what we do know is that lots of GPs do their checks in the last quarter of the year, so we are expecting that to come up. But the 75% target is a challenging target, and I'm not sure that's whether they'll make that but I think where we were last year, we are slightly ahead of where the percentage target was, how we were doing last year based on it. So hopefully we'll be aiming to improve on last year's performance in terms of annual health checks. In terms of the leader review, which is the looking into the deaths of people, 53 reviews were undertaken in the last year. Of that, 91% really good evidence of really good care being provided for individuals, but in 9 cases there were some recommendation where they said that some of the care that had been support or health services people have received did fall slightly below what would be an expected level, and so there are some specific recommendations that have been followed up on regards to that on a routine basis. In terms of what we call the care and treatment reviews, or the care and education treatment reviews for people under the age 18, the processes are well developed and in place, and there are monthly cohort meetings, but basically every month we're looking at everybody that's either at risk of going into hospital or is in hospital, making sure those meetings, those care and treatment reviews are taking place, and that there are discharge plans for anybody that we know is looking like they're ready to start planning their move to come back into the community and leave hospital. And as I've said, the Stomp and Stamp campaigns around, a lot of the work on this is around medicines optimisation, and there's a transforming group that oversees that. Forgive me, I'm it's probably not my area of expertise, but the polypharmacy and prescribing activity around that, so just sort of how we manage that. And the Stomp and Stamp campaign is really well published, and there's lots of led by lots of national providers as well as the NHS, really trying to raise awareness about the over-medication of people in hospital, especially in particular in hospital settings. And there are a number of actions underway across the system to ensure that this patient group gets regular medication reviews to make sure that's happening. Longer term developments up until the 2023-24, which is when this programme runs to a point. One is that around National Learning Disability Improvement Standards for all NHS funded services, and making sure that those are embedded across those services. A digital flag in the patient record to ensure that anybody going into a hospital, that when they're going in or plans to be going in, that they're recognised as having a learning disability and or autism, so that the hospital can make the reasonable adjustments they need to support that person's hospital admission, and therefore making it work better for them. That children and young people with a learning disability, autism or both, with the most complex needs will have a designated key worker, and that people with a learning disability and autism will be offered the opportunity to have personal health budgets where eligible. In terms of the wider big plan, because I think a lot of that work we've just been talking around sits within what we would call the staying healthy area of the big plan, is that when we reviewed the big plan in its first year, across all the different actions that of which there are 37 within the big plan, looking at progress in 1 year on, we can see that there has been progress in terms of the number of actions moving from completed work 1 year on, work that hadn't started at that point, but which has now moved forward, and the work that's ongoing. So I think 1 year in, we are generally seeing progress being made across the big aims as part of that big plan. Key successes in regard that's been is around the big plan itself, is that we've got really good co-production through the big plan and how we did it, and the Learning Disability Partnership Board that the guys were talking about earlier, that use services and families and the action groups to really involve people in having a say in how we shape the services for them. That we have increased the availability of supported accommodation across BCP, and that's helping us reduce our reliance on residential care, and that we've done really well in securing capital funding to buy specific properties for some of those really complex people that we have in hospital now. And we, just in the last few months, we've supported some really, really complex individuals to move into their own homes with a bespoke specialist support with our own tailored group of staff working with them, and actually they're doing really well in the community at the moment, doing some really good outcomes. We've got a new Woodlark House scheme for young, aiming at supporting people from 16 to 25 and helping to build their skills for independence. Really complex need, and we're looking at another scheme coming online in the summer. We've got a really good long-standing integrated learning disability service, which includes both health and social care staff working together to meet the needs and provide a holistic support offer. We introduced in April, we're just coming up for a year, this a new learning disability care and support framework across the whole of the new council, so that we've got 25 providers that are specialists in supporting people with learning disabilities. And we're doing really well in terms of the number of local services that are rated either good or outstanding with CQC. We have, in terms of the number of out-of-area CCG commissioned adult admissions in the last year, we haven't had any people go out of area into a specialist hospital. So a lot of this is about getting people out, but you've also got to turn the tap off and people going in. So we're really pleased that we've been able to support people that have needed a hospital care in local mental health inpatient services. And there's been some really excellent joint working with staff in our health learning disability services, working alongside staff in the mental health services to make sure that they're making the reasonable adjustments to support people in while they need it, and then help get them back to the community as quick as possible. So that's working really well at the moment. And we continue to work on our risk register. This is where we, every month, the teams work and look at, well, continually really, looking at a register that says who have we got in the community, who are we most concerned about, and they have regular meetings in the teams to sort of say, okay, what steps do we need to put in place to make sure these people, things don't go from bad to worse, and we end up trying to prevent hospital admissions. And I think in the report we talked about the number of prevented hospital admissions we've had in this last 12 months, which is really significant. And as we said, around the implementation of the care and treatment process we've been talking about and keeping that going. And we've got a new Preparing for Adulthood service across BCP, which is enabling us to support young people with special educational needs and disability as they come through and transition to adult services, by really supporting them in that transition phase. Areas that we do recognise that further work is required is around that challenge of that 75% target for annual health checks, and how we continue to build on year and achieving that. How we use the learning from the leader reports to inform any changes around strategic commissioning that we need to do. We are currently undertaking a review of our employment support offer across BCP, recognising that the preceding councils were in slightly different places, and also that we also do recognise that we do have low numbers in paid work, and that's the piece of work that's going on now, which we should have recommendations from in the early summer. The Learning Disability Services building on their strengths-based and person-centred working is one of the key areas of work with the team there. And that's really about how we make sure that the support is around that individual, and actually we build on their strengths, what they can do for themselves, and then just add services in rather than trying to fit them into services. As I've said before, some bespoke accommodation. We're going to continue to keep building that as we need to for the young people coming through that we know we need to move on from hospital. And we've got bids in and agreed with NHS England to help support the funding for that. And really, it's an ongoing thing within the big plan. It's around but it is a challenge. It's about how we support people with learning disabilities to stay safe in their community. Lots of people we support do live quite independent lives, are out there, but actually that does make them vulnerable to and so there's learning from things like a serious case review we've had in the last 12 months, etc. It's something that we keep doing, but there's been some really good work in terms of trying to promote people's safety. Next other piece of work we've got to do then over this next year is a review of our day services, because again we need to look at what that new offer should be for the new council, and again a review of our short break services, what we call respite care. This is where we making sure we've got the right respite services across the conurbation. So they're pieces of work. They're in the big plan, and they're planned, and they'll be going forward this year. Thank you. And again, happy to take any questions, and perhaps Jen will come up as well.
Chairman, I was just going to draw attention to something that is in the report, just to say there has been a local government association process of peer review of special educational needs and disability services, which includes preparation for adulthood. That report will be available to health and council partners, and it is something that we would want to talk to the chairman and the chairman of Children's Committee about how that can come forward for scrutiny, because it will provide lots of good learning going forward. But I just wanted to signal that because the report isn't available yet, but it is mentioned in the report.
Okay. Councillor Matthews.
Got it to work. Thanks, Joe. Excellent report. What I really wanted to sort of focus on was the kind of annual health reviews and so on, because obviously 34% is pretty low compared to the threshold. And the other thing that if we go back to the triangle where we've got a lot of people that we don't know have a learning disability. So I'm kind of thinking potentially that 34% is actually more than that of people who would really benefit from having an annual health review. So that's something I'm quite concerned about going forward. It kind of strikes me that there's a bit of an issue with making surgeries LD friendly. I know it's a term that we borrow from other sort of areas and so on, but clearly to me that would be something that would potentially be a way forward, so that people feel confident to access their doctor's surgery and so on, and that they're empowered to do so. I mean, it's great hearing about the key workers and the flagging up and so on, but these are actually people that we know of. So I'm kind of thinking if you can make this a little bit more ubiquitous, then potentially that's a way forward, and it's actually empowering lots of people who we don't know about. And so that would be something that I would like to see addressed, really, if that makes sense.
You happy to?
Yes. I mean, we anticipate that probably that the percentage of annual health checks would be sort of in the mid-50% by the end of the year, but it's not good enough, and we recognise that. I think that there is something about how we make GP practices friendly for people with a learning disability, but I think almost more importantly, it's how do we demedicalise the offer for people to have a health check. We're really pleased that a number of our primary care networks have chosen learning disabilities to actually really address how they improve the offer for health checks, working with partners to do that for their local population within their network. So we've got a number of primary care networks that are looking at how they can really improve that for their area. We also know that with the changes with the GP contract coming in from April, that will be a further incentive for the networks to pay attention to how do they work with partners to provide a better offer for people to have their health checks, and look at a range of settings where they may be able to have their health checks as well. So this is a particular area for us working with partners that we will continue to focus on, and we really do want to see that improve. The other thing I would say linked to the health checks, in my mind's eye, it's no point just having a health check if you haven't got the support there to offer people afterwards that's tailored to that individual. So we've started to have some discussions with our public health team through Sam Crow, because at the moment the Live Well Dorset offer around lifestyle isn't differentiated to different population groups to be tailored, and I know that they recognise that that is a further development that Live Well Dorset could do. So there is a more tailored offer of support for individuals once they've had their health check to look at how we can promote healthy lifestyles. The other element, looking at Louise, is Louise and Healthwatch have done quite a lot of work around the offer to people with learning disabilities. So we've just started some discussions about how can we work with Healthwatch also to help improve our work around health checks as well. So I completely acknowledge it's not good enough and we need to do more about it.
I just wanted to follow on from that. I just wondered what practically happens when people are invited to have a health check, whether it's that they get a letter and they have to phone, or does somebody phone them, or do they just get sent an appointment? I just wonder if that side of the practicalities has been explored at all?
I'll start, but Joe, I don't know whether Joe wants to add. I think it varies from practice to practice. So I think people would potentially get a letter. And I think there has been work done in terms of how the letter's framed and how that goes out to people. So it's easy to understand and read. But I think I'd say that there's variation from practice to practice. So again, what we want to do is do some shared learning around what works well. And as I say, it doesn't necessarily have to be the GP or the GP practice if they're working with in partnership in terms of how we go out and offer that check to people. Joe, have you got anything you want to add?
No, that's it. No, I think we've there is national level really good recognised tools there, which we've made, which are available locally, that sort of say this is what a good health check looks like. And we've done a lot of work, and so People First Forum, in trying to educate people themselves and their families to know that when they go and see their GP, actually this is what you should be expecting and what you could actually ask for. And the other thing to say is, we've obviously written into the contracts with all of our people that receive commission support to ensure and made lots and lots of awareness training with our providers so that they know what to expect when they go to their GP with somebody and they're supporting them to get that health check. So I think and we service monitor that to make sure that they are making sure that they have supported somebody to go and have to have their health check done. But except for yourself, there's a group of people there that might not.
Now out what to look. First, Val, one of your staff, Val, did it as a little leaflet we could have in his old yellow books, but now it's in the new ones, isn't it, what to look for?
So the yellow health books are an accessible document that people with learning disabilities can use when they're going to see their GPs, and then it will have information about what to expect for your health check.
Councillor Rampton, did you have a question?
My question is really the question that Chris has asked, and it was about health checks, and it is very poor, but actually it's really poor nationally, and 75% is the target. Who's achieving that? Is anybody in the country actually achieving that, or is everybody at that sort of 50-odd% rate? And Sally, you've given a target of 3,009 completed health checks, and how realistic is that? And what percentage is that? Is 3,009 75%, or is that 50-odd%? How have you worked that one out? And I just think it's pretty scandalous, actually, that GPs are incentivised to carry out health checks, and yet the figures are so low. Not just Dorset, but nationally the figures are so low. And I wonder, maybe the People First representatives here could let us know, what is it that puts people off going for the health check? Is it the way that they are approached? Is it the place that they go to? What actually is it that puts them off? And what we could be an exemplar in Dorset if we get this right. And I admire that ambition, Sally, to get up to 3,009. But what is that percentage figure? Is it too low? Is it too high? Is it achievable? Is it not going to be? And I recognise that Health Watch are doing a lot of work. It's on their work plan. What more can be done?
Okay, so that target would be the 75%, wouldn't it? Is that? Well, I didn't write this paper. My colleague Mark did, who's done well.
So I think it is a bit, because the target is 75% nationally that they're asking everyone to achieve. But then I think at a regional level, each area was given a number to achieve. So actually, that number doesn't necessarily then equal 75%, because it's depending on whether there's more people registered with the GP or less for the register, that number may or may not go up or down as a percentage. So I think last year, they, as well as setting this overall 75%, they then said, we're actually going to give you a specific target number to reach. What that equates to in a percentage, we won't really know until the actual end of the year to know how many people were registered at that point in time with the GP. So and we were a bit confused at the time when they set it in two different ways locally, for us to achieve locally. So doesn't necessarily, but it will be trying to push it towards that 75%.
Do you want to just turn your? I suspect that's below 75%, but we can't, as you say, qualify it until the end of the year when we know how many people are currently on the register. Our governing body in the CCG isn't satisfied with 75% as the target. They think it should be 90+%. So, to be honest, no matter what the regional target is, if it's below 75%, we think it should be higher than 75%. So we need to have we've got much stronger ambition around that to give you that reassurance. In terms of, I think if we had a number of GPs here talking about this, I would say that the financial incentive in the GP contract for learning disability health checks is very low, so it's not really about the financial incentives. I think what the GPs would say is about how do they best go about it to actually make sure that the offer is right for people, that encourages people to have their health check. Hence why my reference around their recognition about needing to work with partners to offer it in a wider setting than just the GP practice. So a number of our areas have been working with Dorset Healthcare, for example, to look at how they can offer the health checks. So we need to make it, we need to improve the environment within general practice, but we also need to look at how we broaden that out and engage with people in probably more community settings in terms of where they have their health check and open that out. And that's part of the work that we're doing at the moment, and some of the work that the networks are doing to look at how they can really improve the uptake of those health checks and the subsequent support offer after that.
And Chair, is there a view from People First on what the barriers are to having a health check?
Can we ask?
Even when you go, it varies on practice
Thank you.
I think it's probably just worth mentioning that just generally NHS health checks, there isn't a high uptake locally or nationally either. So we're talking obviously particularly around health checks for people with learning disabilities, but we are, and public health team who lead on this are looking at actually NHS health checks just generally isn't very attractive to our population. So we do need to look at how we engage with people differently around this.
Thank you. Councillor Edwards, did you have a question? Okay. Councillor Dedman?
Yes, thank you, Chairman. I just wanted to say to Councillor Rampton and Councillor Matthews, well, everybody really, obviously, that in the Bill of Rights, which I'm hoping that we will at the end of this sign up to, there's quite a lot of mention of healthcare, and I think that's something that clearly both the councillors would agree, you know, you need to keep an eye on. It's no good saying, well, we've got the right to it. It needs to be acted on, doesn't it? And I mean, and the other thing is, Councillor Rampton mentioned it doesn't have to be the doctor. I think that was you, wasn't it, Karen? The healthcare checks can be done by a nurse, can't they? Which is probably a slightly different kettle of fish, or whatever you call it, from the doctors, as we've heard. So that was all I wanted to say. Thank you, Chairman.
Councillor Evans?
Thank you, Chair. A couple of questions. Firstly, as a GP, may I apologise on behalf of myself and my colleagues that we don't seem to be providing the service we should be for you. I think as GPs would benefit from Shane coming in and giving us some training, please. But I'd like to move on from health checks because there are other issues that we've, I think, need to touch on in the report. Moving on to the leader and the mortality review, I don't think nearly 1 in 10 is an acceptable level of care below expected, what can be expected. So I'm just wondering what we're doing about this. We also seem to be incredibly behind in actually completing the leader reviews. And I believe someone today has just been put in post to help with this. And do you think we're going to catch up soon? Thank you.
Okay, so our Director of Nursing and Quality, Vanessa's team in the CCG lead on this, and they have recruited additional capacity into the team to do more of the reviews. I think I'd say that recruitment isn't easy all round, as you know, but they have recruited additional capacity, so it will pick up the pace of undertaking the reviews. This is an area that we look at through our Learning Disability and Autism Local Board, that we monitor the outcomes but also the themes of the learning. So that was a topic of our last discussion around this at our last LD and Autism Board, which is Partnership Board, around where are we taking that learning, how are we feeding that back to our the providers of those services that are being part of the delivery of services to those individuals. So I think nationally there is a backlog of reviews. This was introduced as a pilot and a testing, but there is a backlog nationally around the reviews, but we have increased capacity, which will mean that we'll be able to pick up the backlog that we've got. We will continue to need to monitor it because it still is a small team and it doesn't take a lot for somebody to go off sick or whatever to impact on the reviews. But certainly in terms of tightening up the closing loop, the feedback loop of the themes of learning, that's an area that we've got particular focus on in the LD and Autism Board in terms of making sure that happens and the feedback goes to the providers and we can see what the learning is from that.
I just would add, I mean, we meet with our learning disability and autism providers 3 times a year at a provider forum. We usually get about 70 or 80 people come along to that event, and that gives us a really good opportunity, and leader is often a standing item on those updates on each time we have one. And also I think it's on the agenda for the next partnership board, which is this month. So again, and we promote information around some of the national learning and local learning, both through that and the Learning Disability Partnership Board newsletter, which goes out to a really big mail out to everybody we know that has any involvement with supporting people with learning disabilities. So again, we try and disseminate all that information regularly through those opportunities.
Thank you. Councillor Trent, did you have a question?
Well, my question actually was more of a comment, and it goes back a couple of points to the point that was made about health checks and the attitude to it. I'm I'm actually one of those people as an OAP with a minor but major lifelong issue. I would be one of those people that would welcome routine regular health checks. But what I've found, and it very much echoes the gentleman's point earlier on actually, is that very often it's getting past the receptionist, and I get the impression that they're there to screen people out and to prevent people from actually going through the process of booking appointments with doctors, because quite frankly you almost get the thumb screw on you as to why are you coming, and why aren't you coming back in 3 weeks' time and things like that. And quite frankly, I think that side of the service, at least in the practice that I have experience with, lacks quite a bit. So I completely back up your point about the way some receptionists do screen people out.
Councillor Lewis?
I was intrigued looking through the report on page 19 under 3 in the table of learning disabilities. The percentage in Bournemouth goes up to 11.18%, which is so much larger than England, say, and it's sort of the growth seems out of all proportion to that of Poole and Dorset. And I was just intrigued to know why that was and what the explanation could be.
Sorry, is that in the main report?
Yes, it's on page 19, under number 3, there's the table. Do you have the, it's
page
just,
19 of the whole agenda pack.
yes, it's just sort of under the start actually. Do you have the table? Sorry.
Expected growth.
Okay.
Yes.
Yeah, so you, in terms of regards to the population increase for...
Yes, the growth from 2019 to 2035, it sort of shoots up from the previous figure right up to 11.18%, when, you know, in Poole it's not gone up that much, and nor in England. So I just wondered what it was about Bournemouth that was...
Yeah, difficult to say.
Sorry.
Some of these tools that they use are estimated are based on... sorry, get used to this. Some of the information that they use for these population predictors tools are based on national information from census and stuff, and they date their best percentage data on it. I don't know specifically why there is such a variation there between Bournemouth compared to Poole, and that was information that we took from some information that's come out from published information around where they expect the population growth to be.
Yes, sorry, I just have quite a fascination for statistics, and I just wondered why, you know, it shot up so much, but thanks anyway.
Okay, it may just be to do with just the age profile of other people within Bournemouth area compared to others. Not some of that you have to do take with a pinch of salt. I think some of it may not always be bang on accurate, but it's best predictors we have at times.
Councillor Evans, you had another question?
Thank you. So looking at the Adult Learning Disability Service, the key strengths I was actually really impressed with. It all seemed incredibly positive, so really good work there, well done. My one concern is I do work out of hours as GP, and I see the service is only available 8 a.m. to 8 p.m. Monday to Sunday. And I was just wondering if you could say what happens outside these hours, or perhaps you feel the service is unnecessary after 8 o'clock, no one has a crisis.
So there is the adult social care out of hours service, so that would be there available to anybody that requires support out of hours. We have, there has often been a look to say, would it be sensible to increase the intensive support service to be a 24-hour service? But I think all the evidence that we've found thus far is that actually that's we haven't found the evidence that says we should be looking at extending it. It's been a little while since we undertook that review, but I do remember us a couple of years ago, and the intensive support service is obviously a health managed service. I don't know, Jenny, whether you've...
No, I think that the out-of-hours service is used, and that is available at all times. So, yeah, I think like Joe says, that there hasn't been evidence to need to extend the intensive support team hours.
A lot of those people that we support who are the most complex needs in their own right will often have their own 24-hour support with them in the home already as part of that support package. So, actually, then the intensive support team might come in, be offering advice to those people throughout the week, making sure that they're getting the support they need and then withdrawing. But yeah, it's not something that we found evidence to say we need to extend the hours for this.
I was just going to say they will support throughout weekends where needed as well. But I think, as Joe touched on, many of our clients that we support with complex needs have support around them, whether that's through a direct payment, supported living, or residential care. So yeah.
May I suggest it might be worth just reviewing that, just to have another look at the evidence, just to absolutely make 100% sure it isn't needed outside of the current hours.
Is there any more questions?
Thank you, Chair. I see on one of our recommendations, C, that a report is presented to the CNU next year. I just wondered if this whole thing about the health checks can come back to us then, seeing if it's improved at all, or they've taken sort of advice from the people that use it. But I know that it's a problem as well with sort of not just learning disabilities. And also any progress on any paid employment, sort of how that's going. It's okay.
Thank you. Is there any other questions? Oh, Councillor Butler.
Yes, I was just going to suggest, has anyone looked at a mobile medical unit going round for health checks? Because I know it's very popular for things like cancer scanning and things like that with the general public. A lot of people haven't got the time or the maybe the ability to use transport to get to a certain appointment, possibly. And maybe if the mobile unit actually went to a place where they know a lot of people will be gathered, that would be an easier catch than trying to catch people individually. So just a suggestion really, especially as lots of people meet in big groups. Could even be like a place of big employment somewhere that people could go along to. So that's just something I wondered whether that could be used.
Shall I respond here? Thank you for that. I think what we are looking at is whether we have a mobile model. It might not necessarily need to be a van, because the types of equipment that you need to do a health check aren't big scans and things that you would have, for example, in cancer screening. So absolutely, we're looking at how do we go out to the community rather than expect the community to come in. That might mean a workforce going out to somewhere. It doesn't necessarily need a vehicle, but the concept is the same in a way.
Okay, so just to sum up, I think we've had some really good discussion, and I'd like to thank Shane and Amanda for a really engaging presentation. It was very well received. And also an interesting and informative presentation from Joe as well, with showing a lot of really positive work that's going on with the big plan. Councillor Matthews had an idea of us having a training session, which I think we can follow up and see if we can organise. And sorry?
So I'm just saying, I didn't. If I probably need someone to second that.
Oh.
Can I just check? Is the suggestion that there is a? I think you described it as a briefing, but is the suggestion that it's for all members, open to all members? So, okay, that's helpful clarification.
Okay. So, do you want to? You've proposed that. and Councillor Lewis has seconded that. Is everybody in favour of that? Yes, unanimous, I think. Great. Okay. If we look at our recommendations, we have a recommendation here that the council adopt the Bill of Rights Charter. Yeah.
Chairman, just for clarification, obviously if the committee are minded to support that recommendation, that will be submitted to the next available council meeting for consideration, which as members are aware is at the end of March, the 31st of March. So that will be a recommendation from this committee to full council.
I'll just clarify, I think Councillor Rampton did suggest maybe the format of that might need to be discussed with the chairman, with the authority.
Yeah, taking on board the comments that Councillor Rampton made, we can look at the options available in engaging with the People First Forum as to how they want to do that. So we'll have those discussions if that's an agreeable approach and come to a conclusion as to what's most appropriate.
I'm sorry, I think you need to clarify for me. Are you talking about recommendation B, which I understood was on this sheet as a Bill of Rights, which we were to propose adoption of, or is it something different?
It is the recommendation B.
You're not going to put it forward, you're going to change it slightly?
No, we are going to put it forward.
Oh, okay. Right, thank you.
Did I... Sorry, was I confusing?
I think the conversation, the discussion at the moment relates to recommendation B. B, recommendation B.
Can I just
Around the
clarify
Bill of
then?
Rights?
Recommendation B, as far as I've got it on my screen here, is just to recommend to the full council, as you said. Recommendation C, as Councillor Rampton is suggesting, is that something comes back before, isn't it? Yes, go on.
My suggestion, Councillor Dedman, was about B, that when the Bill of Rights comes to full council for hopefully for adoption by everybody, that People First are invited to come along and to present it to the council.
Thank you for clarifying. So can I come back then, that on recommendation C, Councillor Rampton, again, it's handy that I'm sitting opposite you, Karen, really, isn't it? We want to see something before that about the health checks, so that although it comes back in March 2021, which is a year, I think we felt, or the committee perhaps felt, that something else, you should formulate an earlier date.
I hadn't got to that bit yet. Okay. So recommendation B, that in conjunction with the Cabinet Member for Adult Social Care and Health, we recommend to Council that the Bill of Rights Charter for people with a learning disability is formally adopted by BCP Council, with quite possibly a presentation. Are we in agreement? Okay. I think we're all agreed. Yeah. Okay. I think so.
Yeah, that's fine. Sorry,
Okay.
just for clarification, no confusion. Recommendation B will be the subject of recommendation to full council, and we will look at the methods by which we can engage with the People First Forum at full council in presenting that recommendation.
Mm-hmm.
Is that agreed?
Yes. I was going to say, so it will be educational, but it will also be funny as well.
Okay, so we also had a good discussion on health checks, and a lot of interesting and important points were made. Councillor Rampton, I think, and Councillor Edwards mentioned about the importance that we perhaps come back earlier with some progress on this in 6 months' time, which which I think we'll all agree to. Do we all agree? Great. Okay, so we'll also add that. And also, you mentioned paid employment, Councillor Edwards. So I think if we could also have a report back in 6 months to include that too. Okay, I think we've come to the end of that item. Thank you very much.
Introduce it now.
Okay, on to item number 7, Health Watch Dorset. I'm going to hand over to Louise Bate, Richard Selby. Is there anybody else? No. Yes. Okay, I'll hand over to you.
Thank you. Thanks, Joe. I've got some leaflets to hand out too, so I'll pass those around. Okay. There you go. So Richard has come along to give me a bit of moral support tonight. Richard is one of our volunteers on our steering group. Thank you for coming. Here we go. I can work the clicker. So I'm the manager of Health Watch Dorset. We're a small team. There's 4 members of staff and just over 115 volunteers across Bournemouth, Christchurch, Poole and Dorset. So I'm sure most of you know Health Watch fairly well, so I'll run through this presentation pretty quickly and then we can get to questions. So we exist to ensure people are at the heart of care. That's what Health Watch is there for. We're an independent way for people to give feedback about all aspects of health and social care services. We share the views that we gather from local people with decision makers in order to make a difference, to improve services. There we go. So we do this in a range of ways by going out and proactively engaging with people. We do that through running events, having stands in places, talking to people, going out to groups to meet people. We're based at the Bridge at the centre by the Little Down Leisure Centre, and we actually share an office with People First Forum. So it's quite nice us being neighbours here tonight because we actually share space with them. And there's lots of events that go on there as well. People come in for, so we've always got a place where we can have events with local people. We provide information signposting, so people contact us directly to ask questions about local health and care services, and that can be all manner of things. We had some calls today from a couple of people who were somebody with autism who's concerned about the news about the virus and wanted some advice, and Healthwatch England have published some advice that we were able to share. We had a question about dentistry, and somebody with a learning disability actually got in touch who'd been signposted from People First Forum to get some information about how to get further advocacy on making a complaint. So all manner of different signposting that we provide. We monitor the quality of health and care services by taking part in this group amongst many others. And really it's about using the voice of local people to influence commissioners and providers. And we're in touch with Healthwatch England, who provide kind of support and information for all the Healthwatch across the country, and work on national issues of importance. And we work closely with the Care Quality Commission and our local commissioners and providers. So I thought I'd just kind of sum up some of the things that we've been doing this year so you could get a sense of how we work, really. We've got feedback from over 1,000 local people that we spoke to directly last year. We ran projects on the NHS long-term plan, diabetes awareness, that was with some young people. We worked on A&E services, particularly at Poole Hospital last year. Produced a film about homelessness, and we've been working on cancer support services, amongst other issues that come up. We've carried out over 200 engagement events. As I said, we've got over 110 volunteers helping us by carrying out visits, gathering feedback, promoting our, helping out with our promotion stands. And we set up a new steering group last year, so that's made up of 9 volunteers who've helped us look at all the data, all the information that we gathered last year and formed it into a work plan for this year. That's some of the work that Richard's been helping with. So our work plan for next year, at the moment this is still in a draft form. We've been sending it out to lots of different people that we work with, including this committee, to get people's ideas and views and just to make sure that we're not duplicating work and that we're working on things that really matter to local people. So we've been commissioned actually to work on cancer support services. There's a pilot project going on in West Dorset. Macmillan are funding some new posts of people who provide community support for people living with cancer. So we've been going out and interviewing people to find out what people want from those posts really, and how to make those roles really benefit local people. We had an online survey where we got feedback from just over 100 people in West Dorset, and we've been out and interviewed I think 37 people living with cancer, and we're just in the process now of writing that report up, so that will probably be published in April. We've been going out and gathering feedback from young people to influence the mental health service review. So by working with Dorset CCG, we've identified groups of young people that perhaps weren't taking part in the kind of online survey and the work they were doing. So we've been going out talking to more marginalised young people. So we've been speaking to young people who've been excluded from school, some young asylum seekers, young people who are homeless. And so we're going to gather that feedback and it will form part of the mental health service review. And then these other work plan topics are for next year. So we will be looking at access to primary care, including, we've just been talking about, learning disability health checks. Some of the feedback that we gathered last year, specifically from people with learning disability and autism, was that they want to see more benefits to them with health checks that are around the whole of their lives. So they want to be able to get feedback there about diet and exercise and transport and where they live and how they live. So that will be how we work on that project. Really, we'll be working with people with learning disabilities to kind of direct to improve the quality of health checks and make them more useful to people. We'll also be looking at working with carers, looking at disabled access. And when I say access to primary care, mostly we mean access to GP surgeries, really. And also, when we've been sending out this draft work plan, we've had some suggestions that we include residents of care homes in that topic as well, and we will be adding that in. A&E, as I said, we did some work in pool A&E last year, and we've just published a report that I'll show you at the end, actually, so I'll talk about that a bit later. And what we're planning to do is work on A&E services in Dorchester and Bournemouth Hospital so that we've got a bit more of a spread of that feedback across the county. And transport, this is probably one of the main things that people contact us about, so it seemed that we need to have that on our work plan for this year. I'm not sure exactly what form the work will take yet. We're going to need to do a bit more research in order that we focus on an aspect of improving transport services where we can actually make a difference. Obviously, it's a big topic. So, and there is our contact details. As you can see, we like a bit of social media. So if you tweet or you like to Instagram, please follow us. You can write to us free. That free post address, you just have to write Health Watch Dorset on an envelope and it will get to us. I'm not sure how that works. It's amazing, but it works. We had a load in this morning. I think that's it. Does anybody have any questions? Oh, I was going to show you the A&E report, wasn't I? Could you get that up, Joe? Thank you. So we did this specific piece of work in pool A&E. We went in over a period of 4 weeks with 5 of our volunteers and a project worker, and we interviewed 40 people who were in the accident and emergency department to find out how they got there, why they'd gone to A&E, and what their experience of A&E was like, really. And this has formed part of a Health Watch England and an NHS England national report that is looking at the new way that A&Es will measure the time that people wait in them. So it's had an impact on the national standards. It's a really good project to be involved in. And on a local level, our local report, we made some recommendations to Poor Hospital, all of which they are going to work with us to achieve. So that's been really positive as well. It's up on our website. I think Joe's just getting that up now. There we go. So if you have a look on our website, on the front page, this will come up on the front page, so you'll be able to click onto it. And the report is further down on that page. Thanks, Joe. Keep going, bit further. There, if you click on that link. There you go. It's not too long, 10 pages, so easy to read, but I'd recommend everyone have a look at it, please. Thank you.
Thank you very much.
Thank you.
I'll open up for discussion and questions. Councillor Rampton.
Thank you, Chair. Louise, my ears pricked up when you mentioned homelessness, and I wondered, I can't see Health Watch being involved in the Homelessness Reduction Board subgroups, and I wondered if that was something that you have not been invited to join, or if there's a specific reason why you're not part of it. And I've got another question, if I may.
No, I haven't had an invitation to join. We'd be interested, definitely. Yeah, thank you.
And on 10, you speak about your work priorities, and I see children, young people and transport are 2 of those mentioned. And I just wondered, in terms of the council, once you've sort of done that piece of work, where that will go to. Obviously, you come to this committee and speak to us, but are you planning to go to the Children's Overview and Scrutiny Committee? And there's a Transportation Advisory Group. Are you planning to go there with your results?
Thank you. I think that any work that we do around children and young people's mental health share as widely as possible. And the transport, it's still in the early process of us kind of developing that work plan at the moment. So we're wanting to work with all sorts of different people, anybody who's willing to work with us, really, so that we can get something done. So so we've sent it to numerous people at the council and invited them to help us with it. So if you've got any suggestions of other people we should contact and keep in touch with me, I'd be very glad of them. Thank you.
I have a question. I just wondered how you come to draw up your the things that you're going to concentrate on. Is that from your talking to people, or I just wanted to have a bit more information about that process.
So quite a lengthy process, I'm sure Richard could attest to. So we looked at all of the feedback that we gathered from local people over the last year, and then we balanced that out with a kind of list of priorities that we work on. So we were looking at having a spread of geography, making sure that we considered protected characteristics in any project that we work on. We looked at what everybody else is working on locally, so work plans for the clinical commissioning group, for the local councils. We looked at what health scrutiny committees were working on, health and wellbeing boards, and also some Health Watch England national projects that are going on, and then looked at where we could make a difference. So there were some topics that people raised with us regularly that we didn't feel like we could have an impact on, and by whittling it down and hours of talking and working through it all, we came down to these, and we've sent these out to a mix of stakeholders over the last month to get their feedback as well, just to make sure that we've kind of picked things that resonate with people and that we can make a difference on. Does that help?
I have another question, if there's nobody else at the moment. I remember, I think last year you did some work on diabetes that was really important, and I just wondered how you follow things up so that things don't just get left. I wondered what sort of process you use for that as well.
Thanks, that's helpful. You're right, it's often the way that we do great bits of work and then time goes by and you're like, what actually happened because of that? We've been sending out, we ended up with a bunch of resources from that piece of work. So we worked with some young people in some schools, and we ended up with a couple of films of young people talking about their experience of living with diabetes, and a blog that a young person wrote for us about living with diabetes. And so those resources we've been sharing with the primary care networks who've got diabetes as one of their projects for this year. And we've been trying to share it with people who it would help them out so that it will carry on being used. And we're also going to continue to do some more work with the schools that we'd worked with around some of the projects we'll be working on this year, so keeping in touch with them too.
Thank you. Oh, Councillor Evans?
Yes, I was very interested in your pool A&E report. It's something I was completely unaware of. I just wondered if it was something either you think it would be worth us scrutinising either now or to see how the recommendations are actually put into practice in the future.
It'd be great to get some backup on checking that the recommendations happen. Yeah, I would be very happy with that. Perhaps if I speak to the hospital and then get back to you with a timescale for when that would be work best. That would be great. Thank you very much. Oh yeah, Richard's just reminded me that so we had, I think, over 20 of our volunteers took part in place visits last year as well. So those are patient-led assessments of the care environment. I think I've got that right. Hospitals tend to invite us to provide volunteers for these visits because they need to have more patients take part in them than staff. Richard took part in, how many visits did you take part in?
I did Poole Hospital and St Anne's.
Mm-hmm.
And so we're teamed up with staff and patients, so we sort of operate as an independent, but basically we go around and inspect the environment, the care environment, and it raised some very interesting discussion, certainly in Poole. St Anne's was very good, but we've had the results back from Poole now as well, haven't we? So,
just this last couple of weeks, the national results are out on place surveys, and so we'll be following up on those as well. So that might be something that later in the year we could share some more information with you.
So are those published yet?
They are, yeah. Shall I, perhaps if I send a link to Joe and Karen, they could share it with the committee, if that's useful. Thanks.
I think that's all of the questions. So thank you very much for coming and presenting to us. So our recommendations to look at. Recommendation B is that we ensure the committee develops its forward plan and takes into considerations the priorities that you have raised, and that we're working together and avoiding duplication. And we have a planning day coming up in June, so we will be taking that into consideration. C, to continue to invite a Health Watch representative to be an observer at our committee, which I hope you will.
Thank you very much. And I might see if sometimes Richard and I might share that role in the future.
Yeah, good. And to ensure that we have your annual report looked at on an annual basis.
So, we write up our annual report and it needs to be published by the end of June, just to give you a timescale of when we'd be publishing that.
Okay, thank you. Okay, thank you very much. We should vote on the recommendations. Are we all in agreement? Great, okay. Thank you very much. Our next item, item 8, is the Better Care Fund. We have officers Elaine Stratman and Sally Sancroft from the CCG here. Thank you.
Good evening. My name's Elaine Stratman. I'm the Head of Strategic Planning and Quality Assurance for BCP Council, and I'm one of the lead authors on the Better Care Fund Plan. Better Care Fund Plan is an extremely complex piece of work. So what I've tried to do is distill it down to something that's relatively understandable, I hope, for you tonight. So, purpose of the presentation then. So we'll look at the principles of the Better Care Fund Plan. Then we'll go on to talk about the schemes under the Better Care Fund Plan. Then just briefly talk about funding and then look at how we're performing. So the Better Care Fund Plan came about as part of the Health and Social Care Act in 2012. And since 2013, BCF programme has been in place, which looks to join up health and social care, so to deliver integrated services to enable people to have good quality of lives and live independently for as long as possible. So it requires, the Better Care Fund requires the NHS and local governments to actually pool their resources into a single budget. This is sort of like an enabler for shifting resources into the communities, into social care, delivering services closer to home. The Better Care Fund is made up of a number of different pots of money. For example, we've got the Disabled Facilities Grant. That's been a grant that's been around for quite a long time. The Improved Better Care Fund, which is a new grant that we've been having for the last 3 or 4 years. That's to help us supply social care packages, to help us reduce pressures on the NHS, and also to support the provider care market. The plan or the funds are also made up of the winter pressures grants. That's obviously looking at the severe pressures that the hospitals face over the winter and how we can support the hospitals in their working. And also there's a contribution from the CCG and the local authority. So all of that is pulled together into the one pot of money. So we see this as the operating plan as part of the NHS long-term plan. So looking forwards, our Dorset, this is our joint integration plan as part of that overarching long-term plan. Now, for 1920, the Better Care Fund, our plan didn't change that much. It was a rollover from our 17 to 19 plan. That was a 2-year plan. This is a 1-year plan. This is because the government were looking at possibly significant changes over the next financial year. So for this was kind of a steady state place where we were. So a national planning tool has to be completed. So we populated that over the summer, and that was submitted for approval to the Health and Wellbeing Board, because that's one of the conditions of the plan, that the plan has to be agreed, jointly agreed and signed off by the Health and Wellbeing Board. And that was signed off last September. And then the plan goes up to NHS England, who look at and assure all of the plans across the country for each footprint. And our plan was approved earlier this year. So that was good news. So just to quickly go through some of the schemes in the Better Care Fund plan, well, all of them really. There's 5 schemes. The first one is around maintaining independence. And a lot of this is obviously around prevention. So looking at the Pan Dorset Integrated Community Equipment Service, obviously a pool of money is there for prescribing pieces of equipment and kit for people. The Disabled Facilities Grant, so aids and adaptations in the home, that's also funded from the Maintaining Independence scheme. Things like My Life, My Care, our online information and advice offer, that's funded through Maintaining Independence, and also things like assistive technology and having operators working within those operating housing schemes in order to help people if they have a fall in the home. The next scheme is early supported discharge. So this is where we're really trying to make a difference to what's going on in our hospitals, working with our acutes. So we have integrated hospital discharge practices through integrated teams within the hospitals, multidisciplinary teams. We've adopted a 7-day working approach in the hospitals, which we started quite recently. We increased home care capacity, so that was put in place particularly over the winter period where there's significant pressure in the hospital. And we've also put in extra capacity for complex care home placements. So moving on, the next scheme is around carers. So that's ensuring that carers are supported in their caring role, offering respite and short break services. The scheme funds most of those available. The next scheme, moving on from hospital living, Joe O'Connell probably touched on that in his presentation earlier. This is about individuals who have very complex care needs that have been living in long stay hospital accommodation that have now moved out into the community, so require quite significant support within the community in order for them to maintain their well-being. And the last of the 5 schemes is the integrated locality teams. So this is teams made up of social care staff, but it's extended out to involvement of GPs, physical mental health teams and the voluntary sector. So this would include people like your district nurses and your community matrons. So just really briefly there, the funding, so you can see how each scheme and how it's been apportioned money, either through the CCG or through the BCP contribution. And just lastly, I just wanted to touch on performance with you briefly, because the Better Care Fund has 4 national measures that we have to measure against. So as you can see, the first one, non-elective spells into hospital, so emergency admissions basically. So I've had some new data come in today. So from April to December 2019, the outturn was just over 40,000. So that's better than we'd actually predicted. However, it's still unlikely we're going to meet the target of 51,246 for 1920. Metric 2 looks at admissions to residential nursing homes for people over 65. So from April and December, the outturn was 356.4 per 100,000 population. I do appreciate these are quite complex stats here. However, we do have a little bit of concern over the data, so we're looking at the veracity of the data at the moment and whether that's a real true reflection, because that is really, really good performance. So we just want to double check that. Metric 3, percentage at home 91 days after discharge. So this looks at people who, after they've been discharged from hospital, will have a spell of reablement within their homes or rehabilitation. So from April and December, it was about how many people have we still got at home after the 91 days, and we had 76.6% of people still at home, so therefore just missing our target of 79.7. And metric 4, delayed transfers of care. So these are people who are delayed in a hospital bed when they really should be discharged. So from April to November, the outturn was 34.4 bed rate day, which means that within a day there was 34 beds delayed, with our target for 1920 being 25. However, there is a caveat to that, because when that indicator, that's a national target we've been set, we have gone back to NHS England and said to them, this is only reflecting the Bournemouth and Poole Health and Wellbeing area. This is not taking into account Christchurch. So as part of the winter discussions and as part of the next round of planning, which we're expecting to come out shortly, Christchurch should be taken into account in that indicator, because there's likely to be extra bed days on top of the 25. And that's the end of my presentation. Thank you.
Thank you very much. Can I open to questions? Councillor Evans?
Thank you for the presentation. So going back to the metrics, I'm a little confused. Is the 4th metric being met or not being met? Because it says in our report it isn't, but you've obviously got it green on the screen.
The bed days, what, the 25? The 25. So we obviously not, because our target is 25.
Should be red, shouldn't it?
So it should be red. Was it green?
Yeah.
Oh, apologies. It should have been red. It should have been red. Apologies. Yeah.
So as a follow-up to that, we're not meeting 75% of our targets. Do you feel this is acceptable, and what can we do about it?
I'm happy to help out.
Okay.
Touch to this, got it. I'm going to sort of set this in a bit of the context, because the Better Care Fund has got a set of metrics attached to it, which you've seen, but actually it very much links to our wider work within Dorset around how do we grow our capacity and capability within our primary and community services to try and reduce the reliance on hospital services and get in earlier and working with our local populations. And this isn't something that's going to happen overnight. So we aren't alone in this. Across the country, you'd have heard about the level of pressures within the hospital trusts around non-elective admissions, people delayed in hospital. So one of our major pieces of work as a system, which you'll be aware of, is how do we have an investment stream into primary community services, which is what we've been doing. and how do we then also make best use of the existing resources that we've got in terms of the skills and capacity of our joint workforce within our primary care networks. And when I talk about primary care networks in this context, I mean not just general practice, community services, the adult social care services, and how do we bring those together to really identify our most vulnerable population, engage with them earlier, and also be able to mobilise much more responsively rapid response services to those people to make a difference to their reliance on hospital, but to improve their outcomes and their experience. So this is a major piece of work that we're doing as part of what was the clinical services review and the implementation of that. And the changes that we're making, we've just made year one of the first stage of investment, which was 6.5 million. We've now also got the primary care network investment stream that came in from July this year and steps up again next year. So all of these things working together, so it's not just about the investment, working together and how we do that to deliver those services within the community, we think will make the sustainable difference on hospital utilisation and therefore the impact on performance. But it doesn't happen overnight. We're starting from a really low base. When we look at the workforce and therefore the investment that's gone into the NHS nationally and locally over the last 5-10 years, you'll see a steady increase in the hospital workforce around doctors and nurses, and I know I'm telling grandmother suckheads here, and a steady decline in terms of GP workforce and therefore investment. So we are really starting from a low base. And in fact, in Dorset, we've made an early step change in terms of trying to turn that tide of where we place the Dorset NHS pound by investing into primary community services in addition to the national funding that's coming down. So we're going in the right direction, but it actually, it isn't gonna change overnight. And at the same time, our demographic in Dorset means that we've got increasing demand on all of our services, including hospital services.
Councillor Rampton.
I did it first time. Thank you, Chair. My question is very similar to Councillor Evans' question, which is about the metrics, and 3 out of 4 we're not meeting. And does it put funding at risk? Does it put the reputation of the system at risk because we're not meeting the DTOC in particular target? I know that you've said, you've put a paragraph there, I have read it, but Christchurch is a relatively small population compared to the Bournemouth and Poole populations, and I wouldn't have thought it would make a huge amount of difference. And my other question, which may be a little bit contentious, I suppose, is that you've given the outturn as a system, but do you have the figures which break it down into health and into social care?
So I'll maybe take the second question first, but Elaine might want to contribute to that as well. So the metrics that are set for the Better Care Fund don't separate health and social care. The whole idea is that you look at it as a system. So they're set for us nationally. We do also monitor delayed transfers of care through many other routes as well. The methodology and the metric that's used is slightly different through our NHS performance, and then we do look at it and distinguish it between local authority delays, NHS delays, but the Better Care Fund looks at it as a whole and as a collective.
So, do you have those figures to hand?
Yes, I've got some data to hand. Yeah, I'm happy to share them afterwards and send a report out that you could have a look at, or I've got a report here that I can share some data with you. It is a different, like Sally said, it's measured in a different way though. It's a different calculation. I've got November data here. So just bear with me a second while I find BCP. So for NHS, like I say, this is a different measure.
This is bed days, isn't it, I think?
Yeah, but it's divided by 100,000 population as well. So it's quite difficult to understand. But so for bed days, for November, for NHS, there was 765 bed days. For social care, there was 35. And for joint, there was 110.
Is that just BCP?
That's just BCP. That's just BCP area. So in regards to how that would rank, if you were ranking that by local authority area, so for NHS that would be 123rd rank out of 151 local authorities. For BCP that would be 13th out of 151, and for joint delays we would be 131st out of 151 local authorities. So yeah, that does give a different context to it.
Shall I go to your first question? We don't believe, and I'm saying this, and colleagues might want to chip in, but from our experience, because we haven't met those targets, I don't think ever since the Better Care Fund's been in existence, if I think rightly, from predecessor organisations as well, we don't think that it's got an implication for funding. They've never removed funding from our system as a result of the Better Care Fund performance indicators. Reputationally, we never really want to not be performing. We know that if we've got a lot of people delayed unnecessarily in hospital, or we've got people being admitted to hospital unnecessarily, it's not good for patient outcomes. So we don't want that. So reputation, it's not a good place to be. Having said that, we're not the only area across the whole country. You hear it on the news every day. They are really struggling with the amount of demand, emergency demand in particular, into hospitals. So I firmly believe that the track that we're on in terms of really making a significant focus on growing our primary and community services across health and care is the right direction of travel that we need to be doing, and we need to continue to do that and work effectively together to achieve it around the locality, now primary care network teams that we referred to. But we do need to hold our nerve, and we need to keep continually convincing the system that that's the right thing to do, because we could quite easily go back into a situation where all the investment goes into hospitals and not into primary and community services, which is not a sustainable solution in the long term.
I have a question. Could you give some examples of the sorts of when you have a non-elective spell, what sort of health problem is causing those non-elective spells?
Yeah. So we know for hospital usage, then a small proportion of our population use the biggest proportion of our hospital services. So a lot of people that would tend to go into hospital in emergency, it can vary, but most likely it can be people with multiple long-term conditions, for example, whose needs are exacerbated. So they might have a combination of diabetes, dementia, other long-term conditions. They might then get an infection which exacerbates their confusion, and they could end up entering into urgent care services. It could be a child. So, it can be across the age spectrum, but on the whole, it does. The people that use urgent care services the most tend to be those people with long-term conditions and potentially multiple long-term conditions. Hence why one of our strategies is how do you really get to know your population earlier in terms of who those people are that are currently most at risk and got most complex needs, and who are likely to become those people if we don't engage with them earlier, wrap services around them, engage with the community and voluntary sector as well as our health and care services.
Maybe just worth drawing attention to a couple of other things. Louise mentioned in an earlier item the issue of primary care and care homes. One of the important pieces of national work this year will be a requirement for primary care networks to provide very good health care into care homes. So one of the issues we're trying to look at collectively is how do we enable people to receive their health care in a care home and not require transfer to a hospital setting. That's something that will be a real focus. The other thing I just wanted to draw attention to that we are looking at, and there's been some needs analysis done, is the number of people who fall and may then require hospital admission following a fall. And that's something that we really want to do more work to understand what all partners can do to prevent falls and therefore non-elective admissions that are a result of someone falling.
Thank you. Councillor Bartlett, would you like to come and ask your question?
Thank you. Good evening, everybody. Thank you for allowing me to come and ask this question. By way of background, and I promise you there is a question at the end of this, I live in the Red Hill and Northbourne ward and I represent it. And there is a former care home called Templeman House in the ward. Up to 12 months ago, it was in full-time use and it was run by Care South, I believe. No, it's been empty for 12 months. It's now boarded up. When my ward colleague, Jack Edwards, and I found out that the intention was to close it down, we went and had a look. We were accompanied by a BCP property person, and he showed us around. It's quite a big building. It accommodates about formerly about 40 people were living there in the care home. Structurally, the building is pretty sound, although it looks pretty untidy inside now, as you can imagine, and it's probably degraded a fair bit over the last 12 months. So the obvious question for me, and I'm one of these people that can't throw anything away, so I really just have to make sure it's absolutely no good at all before I throw anything away. And of course, a building of that size, it's a substantial cost to build a building like that, a long lead time, and many millions of pounds worth of investment in order to provide it. So I just wanted to make absolutely certain that, you know, if it had a future, what could it be, and what were the plans for the site. The current plans are that the building will be knocked down and demolished and affordable housing will be put on the site. Now, there's some very good reasons for that, and I'm perfectly open-minded about affordable housing. I'm a strong advocate of affordable housing, but I still wanted to make sure that, you know, we looked at because of the potential loss of a very costly and expensive building, could we just make sure? So I did take advice along with Councillor Edwards, and we were briefed that the potential for its continued use as a care home was absolutely not the case. It didn't have the ensuite facilities, didn't meet modern care home standards, and the investment required in the building made it non-viable in terms of its future. So, okay, fair enough. But I then continued to see in the news and locally about the issue about bed blocking. I'm sorry if I'm using the wrong terminology, but I'm a bit out of my comfort zone here. And there are real issues about moving people or recovered patients into accommodation, albeit on a temporary basis, before care packages are put in place or that suitable accommodation is found for them. And this is a national problem. And of course, immediately I thought, well, hang on a minute, it's a 40-bed care home used only a few months ago. Would it not be possible to use it as that kind of interim accommodation? Now, obviously, the issue about standards was one that crossed my mind, having been told that standards were, you know, it wasn't up to standard. But of course, then, you know, not everybody in a hospital ward environment is in as an ensuite facility. In a ward, they tend to have several patients in a ward, and in that fact, in this care home, they actually would have private rooms, albeit they would have to share some of the facilities. So it made me think, you know, is there any possibility that this building could be of use? And that brings me to the question. Is this something, and I just really want to make sure everybody's thought about this and considered it, and if the answer is no, it's not, then that's fine. But, you know, is this something that the committee would be interested in thinking about as a potential option, and is it something that you'd like to discuss for the NHS? And it was interesting hearing the brief just then about some of the issues about moving people into accommodation, and it just seems to fit actually in with some of the things that you're saying. So is this something that you want to discuss? Is it something you want to put to the NHS or collectively move forward on it? That's the question. Thank you.
Thank you, Councillor Bartlett. I think we have many of the right people here tonight to answer your question. So who am I handing over to? Oh, so over to Leslie, if you're able to answer. Thank you.
Thank you, Chairman. Yes, the actual question is, and I'll read it out because I've got your piece of paper here. the benefits of the availability of an almost ready-made facility are obvious. Now, I've got a whole paper here, which I think we've been through a couple of times, haven't we, about Templeman House. We have actually contacted the NHS again this week to get confirmation, and I totally sympathise with you, Councillor, I totally do, because it's awful to think that great big building, and I went round it last week, and actually it isn't in too bad a condition, in the sense that you'd think, oh, perhaps something could be done, but the NHS are not. They advise that a property of the nature of Templeman House would not meet the building regulations for use with NHS patient purposes, which are strict. They advise that the property could not be used to provide care for patients. So that's that avenue. Now, I'm perfectly happy for the committee to start all over again, but it seems to me that that we'd be going round in circles. I mean, one of the things that I did look at when you talk about ensuite facilities, well, I don't have an ensuite bathroom, but then if I was in a care home, I would expect to. But I totally sympathise. I don't know what more we can do, really, if you do want the committee to go and approach the NHS again. Or indeed, if we can approach you right now this minute over the table. But we have tried, Steve, Councillor Bartlett.
Shall I just add that as the NHS representative here today? We have considered your request and been in discussion with our Director of Nursing and Quality, Vanessa, and there are really high standards of building that we would need to commission any services for the NHS. So our standards are no less than that of the local authority. So particularly when you look at the infection control requirements, which are really important, then we wouldn't be able to commission a facility of the nature and the state that it's in currently for NHS services. So I'm sorry.
Oh, please don't be sorry. I mean, I'm glad that the question has been asked and the NHS has come back with an answer, and that's all I can ask. I have to say that investment in an existing structure obviously has got to be probably a preferred option than building a new one from scratch when you look at the relative costs. But that is a subjective statement. I understand that. But no, thank you, Chair.
Phil, did you want to say something?
Thank you. Thanks, Councillor Bartlett, for bringing the question, actually, because I think it's helpful to have this discussion in committee. When we discussed this last year, I think pointed out if we did try to refurbish the home, because you could argue that it's a less costly affair than building a new one, actually we'd need to lose a third of the rooms to bring them up to the standards we would expect these days in terms of space to adequately meet the care needs of people. So you've got to be able to move around the room, both sides of a bed if people. We deal with much more complex care than we did when that home was built in the 60s. And the reason that the care provider gave the building back was because they couldn't fill it, because the people that we wanted to refer to them had such needs that they couldn't meet it within the confines of the building. So quite small bedrooms for the majority of them. Some are larger, but the majority are small. And you can't get around both sides of the bed. So if you need to move someone, transfer them or hoist them, then it's really difficult, and you put both the person at risk and the staff member trying to move them. So it wasn't that we discounted it out of hand. We did look at it and see whether, and we would lose about a third of the beds. So it would take it down to something like a 20-bed or a 25-bed home. The cost effectiveness of running the homes of that nature didn't interest the provider, and quite frankly, we can come up with a much better viable option. And for interim bed capacity, I think it's worth saying to committee that we are able to and have accessed interim beds for people who have required that kind of care on discharge from hospital. And we've been doing that all winter, along with our colleagues. But we only deal with a proportion of the people that go in hospital. So a lot of people are self-funders who don't have any contact with social care or are eligible for our support. And they're some of the people who are using the bed spaces because they need to go home but may have reluctance from family or friends. So it's quite a complicated picture that we paint, and working alongside our colleagues, we always want people as a first resort to go back to their original home and be cared for there. Care homes are our last resort and are used only for those whose needs are such that they can't be safely cared for at home.
Go ahead.
I thought I was doing that properly then. There was just one last thing that I wanted to mention, that we've also got a note here that the housing colleagues have looked at the building with a view to temporary housing accommodation, and not even that. You know, I totally take your point. It's so sad to see it sitting there. When I went round it, I did think, wow, you know, this is a great big building, but it's just not going to be viable. But I think perhaps the committee could, you know, give a push as to when are we going to get it knocked down and affordable housing put up there. So there's your challenge from me.
I think so. Thank you very much. Do you think we've explored it fully?
The only thing is, because this is my lack of knowledge about the type of patients, recovered patients, that might need interim care, because I understand the rationale completely with regard to some, you know, the type of care patient that was living in there permanently before. But this, well, I would imagine it's a different type of patient necessarily that would require interim care. Wouldn't need the sort of level of care. You know, I don't know. I mean, you know, maybe it could be a young person who's just broken a leg or something. I just don't know. I've no idea. And that's why I was thinking along the lines that I was, because, as I say, if somebody is in a hospital ward environment and they're sharing facilities, you know, and you can place them in a similar facility, albeit with a private room, you know, it's actually a betterment for them, and they're moving on, and it's leaving a space in the ward. Which is what you're after. So, you know, whilst I understand exactly what you're saying about permanent places in the care home, I thought that would be different from an interim care requirement. But, you know, I bow to your professional judgment on this, obviously.
I think Sally would just come back on that.
I'll just share with you. I think maybe on some years ago that might have been the case in terms of people having less complex needs. But now, if people have got less complex needs, we will get them home and we support them straight home. We wouldn't want them to go to an interim placement because it deteriorates their rehabilitation potential. So people with less complex needs, we would get them home and provide the support in their own home. It's the people with very complex needs that need to be in a 24-hour accommodation, even if that's interim, hence why you then do need to be able to use the right equipment to support that individual.
Councillor Edwards.
Sorry, I don't want to mention Templeman House. It was just going on that about the maintaining the independence, when you say that you provide them with equipment. Now, is that means tested, or is there a ceiling on the equipment that you will provide for people, or do people have to, you know, self-funders, are they paying for that equipment to make themselves independent in their own homes?
So the provision of equipment's a universal service. It's free, and we don't cap the amount of equipment that a person can get. It's about how we can enable their independence. So some people have 4, 5 or 6 pieces of equipment, ranging from riser recliner chairs to aids that help them stand and transfer from a bed to a chair, or a perching stool in your kitchen so that you can cook or wash your dishes. So that there's a whole range of things that go from very, very small amounts of money, you know, £1 or £2, £5, up to quite complex pieces of kit that could be thousands of pounds for particular individuals.
Can I just add to that? This is an area where we jointly commission the service, and it is a truly pooled budget between ourselves and Dorset Council. We do have a governance around it, so there is a catalogue that the health and care professionals use to order and get the equipment. So we make sure that we don't limit the amount of pieces, but we do ask the professionals to work within a remit to make sure that we're using the most cost-effective equipment for that person, and that we also, when it's finished, get it back and recycle it, so we get efficiencies through that as well. And then within organisations like NHS organisations, all the local authority like OTs or nurses that are ordering the equipment, there is a governance around, as the equipment goes up in cost, if it's a pressure relieving mattress that's very expensive, we would expect a more senior practitioner to have oversight before that's ordered. So there is a governance around it, even though it's not limited or capped.
Can I just ask then? So, say you're a carer for your very elderly mother or something, and she's starting to struggle in things in the home, but she's not actually under your watch. You don't really know about her. So they could come to you then and say, I really think she needs a walk-in bath or something like that. So is that something that you would undertake, or is that? I was just wondering if that's something that they have to be under your watch, or whether they would have to fund it themselves.
You've strayed in around things like walk, particular bath. No, it's absolutely a really good example. Then that is where, so equipment up to £1,000 is absolutely free to everyone. If it's an adaptation to your home, so to create a level access shower or a particular type of bath, then there is a limit on the grant that through the Disabled Facilities Grant, which is currently capped at £30,000. So if the adaptations are beyond that, then we would look to the families about how could they help in funding that. But that's usually the more complex one. So an adaptation to a bathroom is just a few £1,000s normally. It's when you get extensions on houses to meet particular needs, certainly around disabled children or particular disabilities of adults, where their care needs are such that they need a dedicated space with, say, air conditioning and other types of arrangement. So the person you refer to as an example, then if they wanted to seek support, then they could make a referral in through the front door of social care and ask the question. They could even do it through their GP. They could say that my mum's struggling, or the person I care for, and that referral would then get passed through to possibly a health OT or physiotherapist, who would then assess and decide on whether they were eligible or that was the right kind of adaptation or piece of equipment they needed. But they would work together, so health and social care would work together on those, unless it was very clear cut one way or the other, it was health or social care.
Do we have any more questions? If we look to the recommendations, recommendation B for the committee to consider if it wishes to request further reports in the coming 12 months to look at in full or specific parts of delivery or performance. Do we want to look again in 6 months at any of the metrics? What do members think?
I'm not sure. I'd get a steer from Elaine and Sally, but I think it's such a slow process. I'm not sure a 6-month review is going to help, but obviously I'd be interested to see what they think.
I mean, I'm not sure what's on your forward plan, but what we could do, what I would imagine will come to the committee sort of later down the line, possibly October time, is you'll probably want to see something around our end of year performance for adult social care anyway. So we could actually bring something back around the Better Care Fund as well at that same time around the metrics.
And 2021 plan.
And yes, possibly, and around the 2021 plan, if the committee would like to consider that. Probably October would be quite good timing, I think.
Yeah.
Okay, are we in agreement? Is everybody in agreement? Great, thank you. Okay, thank you very much. With that, we move on to agenda item 9, which is our portfolio holder update. And we have Leslie Dedman, who's going to give us a verbal update on her key areas of work.
Yes, there was some thought that I might be giving you a huge presentation, but sorry. There you go. No, thank you. Yes, I'm not sure what sort of update you want. So I've really looked through my diary, and I can tell you where I've been and what I've done. One of the things I think you might be interested in is that there was a couple of briefings on the hospital merger since we last met, with nothing particularly to report except more of the same. In other words, I've noted down in my diary, they're convinced that ambulance trips will fall. So those sort of things, reassuring words from Debbie Fleming. And obviously quite a bit about the A&E, which still seems to be a bone of contention. So that was that particular thing. One of the notes I made as well from the Health and Wellbeing Board, which was, I think, after we were here, because it was the 30th of Jan, I noted down that they're interested in how the local plan, which BCP is doing, oh, hang on a second, I'll put that down, how the local plan, which we're doing for BCP, is going to impact on health and wellbeing. And I think that's really important. And I think that that's one thing that we could really keep looking at because, for example, we've got on our strategy for BCP vibrant communities, well, so has health and wellbeing. So it all joins in. So that's one of the things. They've got a task force to look at that. And I think, again, this committee might well want to see what's happening with that. That's going to be discussed with Health and Wellbeing in June, so then you can perhaps bring more back on that. And I have a note, which I think is not, which is in the public domain, that there's the chair of the integrated chair system. Is that in the public domain now? Because I have got it written down, Jan. So it's a lady whose name I kept forgetting, has been appointed, I hope. Jenny Douglas-Todd. They recruited, I think there were about 6 candidates in the end that we looked at. I think there were many more. There was not a single candidate that you would think, oh dear, they were hopeless. They were all absolutely excellent. But Jenny Douglas-Todd was even more excellent than them. And one of the things I would mention that she has been involved in is Southampton Hospital. She's over there as a non-exec director, so she's, pretty much up to scratch. And also, she's been involved in army counter-terrorism, which is sort of quite an interesting background for somebody who is also very interested in health. So that was that page of the diary. There's been Safeguarding Adults Board, there's been the Joint Public Health Board, and one of the things that I would like to dwell on is that there were the providers event for the safeguarding. Hang on, I can't read my own writing here. It was put on for the providers for learning disability carers and providers. And it was a round table discussion. There was a little bit at the beginning, which unfortunately I missed because I was late getting there, a presentation, but then the round table discussion was absolutely fascinating because it was the lived experience of people who actually are doing the caring and the looking after and the providing. And one of the things that I did note was that there was such a divergence of opinion on what is the right way to do things, so that if you say best practice, and then some of the providers were saying, yes, but how do we know which is best practice for our particular case? So it was very much a learning experience for me. I think it was for all of us, really, that you have to take each individual case. You can't say, well, this is how we do it and that's the end of it. It's all very much got to be an individual case all the time. And that was a really good day. It spanned a day. Right, and I turn over and I haven't got anything else particularly to report. I'm happy to be asked what else I've been doing and I might remember. But and the other thing, Chair, that I want to know is what sort of report you want. I mean, whether you want me to gallop through like that, whether you want me to bring a piece of paper, or indeed I can do a presentation if you like, if I have enough warning.
Thank you. I think it is just this verbal update, not a great big thing.
The other thing that did occur to me was that the committee can, when I go to these things, if anybody wants me to ask a particular question, email through and I can have that in mind when I'm at these meetings. So if anybody wants to do that. So thank you.
Okay. Councillor Rampton, did you have a question?
Very topical question. I just wondered about coronavirus and if you are confident that your area is in a good place to deal with any possible cases in BCP.
There we go. Yes, Councillor. I think we're now calling it COVID-19, aren't we? Isn't that the one? And I've had some briefings on it, and the briefings were, yes, everything is in place if we have a massive outbreak. Now, when we say everything, clearly the detail of the everything is with the Director of Public Health rather than myself and, of course, the NHS. And I don't know whether it would be a good idea perhaps to offer that we have a briefing on it at some point next week, if that's suitable. Oh, hang on. Yes, Jan.
So just one thing to say is Sam Crowe, who is the Director of Public Health, has produced a briefing for members, which we would anticipate probably can go out tomorrow. So I think that will be good to have an update. So we're just confirming that overnight, but hopefully we can get a briefing out to members, because it is a fast-moving thing. So Sam was concerned that to supplement the information which is available on our and hopefully people are looking at in terms of the information that's already available on our intranet, Sam Crowe will produce a briefing specifically for members.
Can I just say, Chairman, when this outbreak broke out, I actually asked Sam Crowe about masks, because some of my residents, I'm sure some of yours, have said, well, you know, are we supposed to be wearing masks? And the advice that I got then was, no, they're no good at all. So that seems to be, you know, it's that thing about you look on the television, everybody's in a mask. So I perhaps, but the main advice at the moment is keep washing your hands.
Councillor Kelly.
Thank you, Chairman. Actually, this is probably a question for Jan. Absolutely, Director of Public Health is going to be in overall charge of this and needing to produce plans. But as a council, do we have a plan? Because there's a lot of departments, and the health generally of our population will depend on what happens. And just could I say, I've heard that everybody in London Underground is now wearing masks. Crazy.
Actually, can I just say, I was there Saturday and Sunday, and I saw one person in the
Oh, somebody else. Oh.
going from Waterloo all
Okay. Variable.
Okay, on the masks, I think I might just ask if Sam produces a little paragraph on the masks, because I'm very concerned that all the time we refer back to our public health colleagues. So we'll just maybe just add. I think they're okay with this. No, well, I think we'll just ask the Director of Public Health in your briefing to just cover what is being said about masks. So we'll just do that, because I think we just want to keep referring back to what is the advice from those who have the expertise. In terms of the council as a whole, we have had discussion across the council led by Sam Crowe, and we are looking at the necessary actions in all areas. We will be looking at that given the state that we're in, which has been preparedness, and you know, obviously it is moving every day. There is national guidance, so there is national guidance for areas such as education and for social care, and obviously you know, if we take those examples, we are looking appropriately at how do we use the national guidance for all specific areas. So yes, we are and will continue to plan as a whole council, and our Director of Public Health will be informing that, but yes, as a whole council we will be looking at the appropriate steps at each phase. So yes.
Councillor Trent.
Yeah, can I ask about national guidance, because some of it so far, and I don't know what's happened today because I haven't seen or heard the news for most of today, but they were talking about in schools, for example, the solution to it was going to, you know, say put 50 kids in the class where there were 30 kids in the class and so on. And the whole essence of this coronavirus or COVID-19 is that its ability to spread. And I would have thought that as BCP Council, we ought to be thinking about ways of avoiding situations where you have crowds of people. Possibly there are certain meeting environments which I don't think are conducive to good health. If people started sort of catching it, spreading it and carrying it. And it does seem to me that unless the advice has improved dramatically, most of the advice seems to go completely against everything that we've kind of heard about it so far. I think it was to bring back retired people to teach in schools and things like that. It seems to be totally bizarre what I've heard so far of the national guidelines.
I think that's why we need to wait for the proper advice, because I think there's a lot of information out there at the moment, and we want to make sure we're talking about things that have actually been advised. Did you want to say something more?
I think thank you for people's comment. We will distribute the Director of Public Health's further briefing. We are working in the context where there is national guidance and it is developing, so as a council we will work in the framework of national guidance, obviously, and the advice we get from our colleagues in Public Health England, as well as our own Director of Public Health. And I would just want to say, I think I'll take from this committee that we may want a couple of members around have talked about whether we need face-to-face briefings. So I'll take that back and we'll ensure that we discuss that tomorrow as a corporate management board, because except that members may feel that they need an opportunity for being able to ask questions and address things, I'm not going to comment because it is the province of the Director of Public Health. So I think we do need to create opportunities where we're talking to the experts and working in the framework of national guidance.
So I'd like to thank you, Leslie, for coming and giving us a briefing this evening. Did you have a question? Sorry.
Sorry. No, it was just an observation, actually. I just wondered how we were doing. There was an article in the Echo about, I think we were being swamped in the deprivation of liberty applications, and I just wondered if there was an update on that, whether that was right or whether it could be something sort of brought to the next meeting. That was all.
I'll just comment briefly on deprivation of liberty safeguards. Deprivation of liberty safeguards, if people are aware, is the process that's gone through when somebody in a care setting, can be a hospital, can be a care home, in a setting where the receiving care has their liberty restricted in some way or other in their own interests. So that's a complex process of assessment that doesn't only involve our trained social work staff, but also involves medical assessment as well. What happened some time ago, a little while ago, was that there was a case law. There was a case law made which expanded the criteria for this assessment really widely, and that left a situation where a great number of authorities, well, almost majority of authorities, then had far more assessments than could be processed. We operate a very stringent process in line with national guidance issued by the Association of Directors of Adult Social Care, where we triage our referrals in order to be able to ensure that we do the high priority cases. There is, as elected members probably are aware, a new piece of legislation called the Liberty Protection Safeguards, which will replace the deprivation of liberty safeguards, and we are awaiting national guidance in relation to that implementation. We have to say at the moment we have had some apologies about the national situation delaying that at the moment. So that will change the legislation, and that will change how we operate. The short answer to the question would be, if members would like to have a much more detailed item on the current, but also importantly the future legislation and how will we be enacting that would be something that we'd be very happy to bring onto your forward plan.
We'll move on now to item 10, the forward plan. I'd like to I'd like to propose an additional item for the meeting on the 27th of April, and that would be that we receive a report and presentation from Debbie Fleming, the CEO at the Royal Bournemouth and Christchurch Hospitals and Poole Hospital. This would be to present the business case for the merger of the hospitals. This is the business case that was approved last week by the Shadow Board for the merged hospitals, and now is being considered by the Competitions and Markets Authority, and also NHS Improvement. This will enable our board to fully understand and comment on the business case. Would we be in agreement to add that to our forward plan for the next meeting? Agreed? Yeah. And just a note that we will get some advice from our legal services about any members who could possibly be on the planning committee for the plans for the hospital, to ensure that we don't put anybody in a situation where they can't sit on the planning board. Okay. Is there anything else we need to particularly talk about? Should I just keep running through them?
You were particularly going to draw attention to the development session and the
Yes, thank you. Just to draw your attention to our development session, which is going to be happening in June. It will be after our June meeting, and we've got 3 quite important strategic documents that will be coming up before then, which is the NHS Looking Forward Plan, the Adult Social Care Strategy, and also the business case for the merger, so they will be able to inform our plans for what we want to look at over the next year for our forward planning.
I suppose the other issue that may arise is that members have just already spontaneously expressed interest in COVID-19 and plans. So it may be that that the chairman may want to explore whether there is how we go forward in terms of this committee looking at that issue. So if the committee were minded, we could suggest that the chairman has further discussions about how best to do that, given it has already spontaneously arisen in the committee, and the committee may well want to take an oversight ongoingly about the issue. So we could also do that.
We have an urgent item of any other business, which is also a confidential item, relating to, it's confidential because it's information that relates to financial or business affairs. No.
Yeah.
Yes. Which is C of Appendix 1 in the Constitution. This means that we'll have to ask members of the press and other people that are not members of this committee to leave.
That's fine.
Yeah.